During this episode of Banner Health's Making the Rounds podcast, we will be discussing pancreatic cysts, genetic factors, how they contribute to pancreatic cancer, and the importance of early detection through imaging and endoscopy. We'll also talk through some of the advantages your patients have in the treatment at Banner MD Anderson Cancer Center, thanks to our multidisciplinary team of providers, tumor board, and more. To learn more about these topics and other cancer-related offerings at Banner MD Anderson Cancer Center, please visit bannerhealth.com/cancer. Making the Rounds dives into medical topics with those who know them best, healthcare providers. My name is Bridget, and I'll be your host for today's episode. If you're new to our podcast, thank you for tuning in. And if you're a regular listener, welcome back. With me today are Banner MD Anderson Cancer Center physicians, Dr. Shivakumar Vignesh, Section Chief of Interventional Gastroenterology at Banner MD Anderson Cancer Center and Professor of Medicine at the University of Arizona College of Medicine, and Dr. Rajesh Ramanathan, Surgical Oncologist and Co-Director of the Gastrointestinal Cancer Program at Banner MD Anderson. Thank you, Dr. Vignesh and Dr. Ramanathan, for joining me today, and welcome to Making the Rounds.
Thank you, Bridget. It's a pleasure to be here. Thank you for inviting me to this important podcast along with Dr. Ramanathan.
Likewise. Thank you, Bridget. I hope that today will be educational.
Wonderful. Well, thank you both for joining me today. Dr. Vignesh, can you tell us a little bit about yourself?
So I'm Dr. Shivakumar Vignesh. I'm an interventional gastroenterologist at Banner MD Anderson Cancer Center. I have a focus in pancreatic and biliary disease, all the way from diagnosis, including screening for gastrointestinal cancers in general, specifically pancreatic and bile duct cancer, and some endoscopic treatment and palliative options.
Wonderful. Thank you for being here. Dr. Ramanathan, give us a little background.
Sure. I'm Rajesh Ramanathan. I'm a surgical oncologist here at Banner MD Anderson Cancer Center. My practice focuses specifically on liver, pancreas, stomach, and other advanced GI malignancies. As part of the program, I also have the honor of steering our GI cancer program, where we look at approaches to really have a holistic approach to patients all the way from screening through treatment and then into advanced therapeutic options, even in later stages of disease.
Well, thank you, doctors, for being here today. Let's go ahead and get started. Dr. Vignesh, can you share with us the role that an interventional gastroenterologist plays when it comes to pancreatic cancer and the prevention in general?
Thank you, Bridget. Just first, briefly, gastroenterologists undergo a very comprehensive 3-year fellowship in all aspects of gastroenterology, including benign and malignant pancreatic disease. Some of us who are interventional gastroenterologists undergo further years of training focused on just pancreatic biliary disease, certain other endoscopic interventions that span the spectrum of diagnostic, therapeutic, and some other options to palliate, cancer-related problems. And we are an integral part of our interdisciplinary team that takes care of pancreatic and biliary cancers at Banner MD Anderson Cancer Center.
Thank you for that. And how about specifically in patients that are high risk for pancreatic cancer? What is the role that an interventional gastroenterologist plays in that?
So patients may have either a genetic or acquired risk factors that increase the risk of pancreatic cancer. And we have the knowledge and the technical skills to help patients understand that risk and do further diagnostic workup to help them quantify that risk. For example, many patients present initially to us with pancreatic cysts, and sometimes they're benign and other times they're pre-malignant. And an interventional gastroenterologist can really help do a variety of tests, including endoscopic procedures such as an endoscopic ultrasound to get close-up good pictures of the pancreas and sometimes even aspirate fluid from these cysts to better understand what type of cyst they have. So we really help that initial diagnostic workup. And in patients with cancer, we can also help stage them and then help them with next steps in their care. We work in a team with surgical, medical, oncologists, and genetic counselors to help patients get the right care.
Thank you for that. And Dr. Ramanathan, Dr. Vignesh had mentioned genetics. So share with us a little bit more about genetics and what genetic factors contribute to pancreatic cancer.
Yeah, so genetics in pancreatic cancer is a very dynamic field where the data is evolving very quickly. We used to think that there's not much of a genetic predisposition to pancreas cancer, but one thing that we know more and more is that up to 10 to 15% of all pancreatic cancers do have some genetic underpinning. So if you think about what that number means, if we have 10 people that we see with pancreatic cancer, 1 to 2 of them might be genetically predisposed to that pancreas cancer. So that gives us an opportunity to intervene early and potentially find their pancreas cancer before it becomes a more advanced stage or a serious problem. And really, genetic predispositions into pancreas cancer fall into 2 categories. There are some folks that have inherited genetic syndromes, and those syndromes have what we call limited penetrance, where just because someone has a gene mutation, it doesn't guarantee that they're going to develop pancreas cancer. But depending on the specific gene that is mutated, they may have a variable mutation or a variable chance of developing pancreatic cancer. The most common of these genetic syndromes are ones that are fairly well known, things like the BRCA mutation, the ATM mutation, the PALB2 mutation. And then there are some that are more specific to pancreases, such as the SPINK mutation, which leads to hereditary pancreatitis. And the range of developing pancreas cancer goes all the way from 5% up to a 40% lifetime incidence or a lifetime chance of developing pancreas cancer, depending on the syndrome. So that's one bucket. But there's another bucket of folks that when you look at their family history, there's just a lot of pancreas cancer there. But when you test them, you don't necessarily find one gene that you can pin as abnormal. So there are some folks that have a genetic syndrome that can variably lead to pancreas cancer, and that all depends on the particular gene and the particular syndrome. But there's a whole other cluster of folks who have some familial genetic predisposition for which we don't have an identified gene. And together, we consider all of these folks as having a genetic predisposition to pancreatic cancer, and that affects how we may start early screening on them as a way of finding issues earlier rather than waiting for it to show itself.
When you talk about pancreatitis, you can live your entire life with pancreatitis and never be diagnosed with pancreatic cancer. Is pancreatitis manageable without evolving into an oncologic state?
Absolutely. And this is where, again, that multidisciplinary collaboration becomes so important because really our gastroenterologists are essential partners in the management of pancreatitis. Pancreatitis is just a description of a condition. It's just when the pancreas becomes inflamed. But the way in which that pancreatitis happens is what determines the risk of pancreatic cancer. For example, the highest cause or the most common cause of pancreatitis in the United States is related to alcohol use. Alcohol use-related pancreatitis' relationship to the development of pancreas cancer is low. But now if you consider folks that either have an anatomic variant of the pancreas that leads to pancreatitis, or folks that have a gene mutation that results in changes in pancreatic secretion leading to more pancreatitis, those folks actually have a much higher chance of leading to pancreatic cancer. So it's not as cut and dry as saying pancreatitis leads to pancreas cancer or it doesn't. There is some nuance, and that's where having that multidisciplinary evaluation of the cause of the pancreatitis has helped us with screening. Dr. Vignesh, do you have anything to add to that?
Yeah, thank you for, again, appreciating our interdisciplinary care, and I think it works quite well. Yeah, so pancreatitis is basically some sort of insult or injury to the pancreas tissue, common cause of alcohol, gallstones, medications. And patients sometimes have these episodes that are very painful, go to the emergency room, get admitted for a few days to weeks. And then sometimes the causes are not apparent. And they get referred to us gastroenterologists, interventional gastroenterologists. And sometimes we do blood tests, to look for some of the rarer causes. And other times, an endoscopic ultrasound is actually very helpful in patients with multiple episodes of this acute inflammation called pancreatitis to find out what the cause is. Are they born with some anatomic condition of the pancreas tube or the duct? Do they have a pancreas tumor? There are times when cystic tumors, there are cysts or fluid-filled sacs in the pancreas, can cause pancreatitis. And other times, it may just be gallstones. And it can also be the other way around. Patients with pancreatitis, an injury to the pancreas, can have fluid leak and form a cyst. That's a benign cyst from that pancreatitis. So as interventional gastroenterologists, we can really help patients understand what type of cyst do they have. Is it benign from the inflammation, or is it a cystic tumor that actually caused the pancreatitis?
So, Dr. Ramanathan, our goal today is to dive into pancreatic cysts. Can you share with us more about, as Dr. Vignesh had mentioned, the pancreatic cysts? How common are they, and how do they increase the patient's risk factor? So, as he's talking about the fluid and the pancreatitis and the pancreatic cysts, what are those risk factors of getting pancreatic cancer later on?
Yeah, Bridget, I think it's first really important to acknowledge how emotionally stressful and distressing it is for any patient as soon as they hear the word pancreas and that something might be on the pancreas. And hopefully today's podcast will make it clear that there is a wide spectrum of disorders that can happen with the pancreas, and not all of them are going to lead to pancreatic cancer. In general, when we think about things that can happen on the pancreas, they get broken down into either solid lumps, which are sometimes called masses, nodules, or into cavities that are fluid-filled, which is what a cyst is. A cyst is a fluid-filled structure on the pancreas. The workup and the pathway for a solid mass on the pancreas is different from a liquid cyst on the pancreas. And today, we're going to really focus on these liquid cysts. The way to think about these liquid cysts is that you can really have three overall categories. You have some cysts that are benign, which means that these are non-cancerous. They're not going to turn into cancer. On the other end, you have some cysts that are pre-malignant, meaning that these cysts, given enough time, will become a cancer. And then you've got a whole category of cysts that are in the middle, where some of them might develop into cancer. And this is why overall, nationally, internationally, there's so much thought being put into cysts so that when an individual patient comes to you, you can try and figure out and advise them on what type of cyst do they have. Is this a benign cyst that's not going to become a cancer? Is this a pre-malignant cyst that you need to act upon soon? Or is this a potentially malignant cyst that we just need to keep an eye on? Cysts are such an interesting topic because they're becoming more commonly detected. As we do more CT scans and MRI scans for other reasons, we're picking up a lot of these cysts that we didn't find before when we weren't doing as many scans. There are some studies that suggest that nearly half of all CT scans or MRI scans will show some kind of cyst on the pancreas. So this is really becoming very common, but it's also an area where there's a lot of research and data going into it, such that we have really well-formed guidelines that inform your doctors, that really inform your team as to how to approach these cysts in a very thoughtful and organized manner. And one of the key actors in that process of diagnosis is our interventional gastroenterology colleagues.
Thank you for that. Dr. Vignesh, when we talk about these pancreatic cysts and the pancreatic liquid cyst, what causes them? Is it dietary? Is it genetic? Is it environmental? What causes these pancreatic cysts?
I think Dr. Ramanathan gave a nice overview, and it is a very broad topic. So I'd like to kind of focus on the two categories. One of the common types of cysts is after the pancreas gets injured or inflamed. Like we talked about with alcohol or gallstones that block the bile duct, irritate the pancreas, or sometimes medications. And then fluid from that inflammation leaks and forms a cyst, which is just benign and inflammation. And the other whole big category is what we call cystic tumors of the pancreas. And majority of them are pre-malignant. And they span a spectrum of low to high risk of turning into cancer. And as an interventional gastroenterologist, our role is to really get a detailed history from the patient, whether it's their alcohol use or their drug use, prior episodes of pancreatitis, family history, genetics, gather all that data. And often we may do specialized scans of the pancreas, either a CT or an MRI scan, which is really excellent for the pancreas as it can look at the tubes and see if some of these cysts can connect with these pancreatic tubes or ducts, and that puts them in a different box. And last but not the least, one of the main procedures we do helps understand what type of cysts these are. That's called endoscopic ultrasound. It's done as an outpatient procedure. It takes about an hour, roughly. The patient's sedated by an anesthesiologist. And we pass this long, skinny tube with both a regular camera, high-definition camera, and a very good ultrasound, a miniature ultrasound, down their throat, into the food pipe and into the stomach. And from within the stomach and the first few inches of the bowel, we can get a very close-up, very good picture of the pancreas because the pancreas is right behind the stomach. So it's really an excellent tool for imaging the entire pancreas, the pancreatic duct or the tube, and solid and cystic tumors. Just the visualization of the pancreas can often give us a very good idea, is it a benign type of cyst or is it more concerning? We have, a whole host of imaging features that we look for. And then we can put in a tiny little needle, like an IV needle, into the cyst and suck out the fluid. And then we send that fluid out for a few different tests, like a tumor marker, cells, to see if they're precancerous cells, and then even some genetic markers. And that's, all available to us to profile the cyst. Is this a high-risk cyst or a low risk or somewhere in between? And then we can help the patient understand their risk for cancer better and what should they do about it. We often will present all that information on our tumor board and discuss it with our surgical oncologists and other specialists. And we develop a plan. These are based on standard guidelines, appropriately adjusted for each patient. And it may involve one extreme surgical resection of that cyst or that part of the pancreas, or often it's close monitoring of the cyst with some type of imaging modality.
And I want to talk a little bit about screenings when it comes to pancreatic cysts and ultimately for pancreatic cancer. We have mammography for screening for breast cancer. We have colonoscopies for screening for colon cancer. We have prostate exams for prostate cancer. What is the screening for pancreatic cancer?
So screening for pancreas cancer is really important. And the reason why is that unlike other cancers where if you catch it early, patients have a really high cure rate, that's not the case for pancreas cancer. We know that even for a very early stage pancreas cancer that's found early, it still has a very high rate of coming back again and of really hurting a patient's long-term chances for survival. So specifically for pancreas cancer, our best option, the best thing that we can possibly do is to prevent the cancer from forming in the first place, which is why there's so much emphasis on these pre-malignant conditions and on screening families. We don't have a perfect test for the pancreas, but the best tests that we have are a combination of MRI and endoscopic ultrasound, because those two tests provide us the best definition of a pancreas cancer. Here at Banner MD Anderson, we have a whole pancreas cancer prevention clinic that is built around identifying the right test for the right patient based on their lifetime risk. And so the way it works out is if we identify someone as having a very high risk of pancreas cancer, that's someone that might get MRI and might get EUS in an alternating frequency to make it less likely that something's missed. Alternatively, if we find someone that has a lower lifetime risk, we want to spare them too many additional procedures. We don't want to overtreat. And so then we have a less rigorous screening schedule. It can be something even as infrequent as an MRI every 2 years for something that we think is lower likelihood of developing into a cancer. So our pancreas cancer prevention clinic is really geared to provide the right screening modality at the right frequency for the right patient based on what we think their estimated lifetime risk of developing pancreas cancer is.
Dr. Vignesh, can you discuss why it's so important for these patients with pancreatic cysts to be seen by an interventional gastroenterologist with an expertise in pancreatic cystic lesions?
Yeah, I just want to reiterate something that Dr. Ramanathan said, because, a lot of this screening, whether it's high-risk pancreatic screening or evaluation of cysts, works really well in a specialized interdisciplinary clinic. So along with our surgical oncologists, we recently started this pancreatic cancer prevention clinic with specifically this population in mind who have higher risk of pancreatic cancer. And as an interventional gastroenterologist, we often are the initial specialist consultation for many of these patients who come with a new scan with a cyst, or they've heard their family member be diagnosed with pancreatic cancer, or someone else in their family with a genetic test, and often they don't understand, the risk, and there's a lot of anxiety. So I feel one of our main roles is to put all this information together and really educate the patient about their risk and reassure them. I often, as an interventional gastroenterologist, will speak to the genetic counselor to get a better understanding if they have other mutations. And if the patient does not come with a specialized scan, often it's a CAT scan done in the emergency room or by their primary care physician, often we'll think about a specialized pancreatic scan. As I said earlier, an MRI is a very good scan if the patient is able to get a pancreatic MRI or a specialized CAT scan. And then we may discuss as a group, what's the best surveillance or screening strategy for that patient going forward. There are standard guidelines that we follow within our clinic, adapted to individual patients. And the two modalities that are best imaging modalities for looking at the pancreas are the endoscopic ultrasound, which has the added advantage of being able to obtain a biopsy if they have a cyst or a solid lesion, or an MRI. And moving forward, we use these modalities to monitor these based on guidelines.
And what is that recommendation guideline for patients who have pancreatic cysts that are identified on a CT, an MRI scan, even if they don't have the symptoms? What is that guideline? I know Dr. Ramanathan had mentioned earlier every couple of years an MRI, but what is that guideline?
Pancreatic cysts are a variety of types, as we talked about, and some are benign and some are precancerous. So it's hard for me to give you one specific guideline. For certain common types of pancreatic cystic tumors, let's take an example as a mucinocystic tumor. Some of them come from the pancreatic cells or from the duct cells. Just as an example, we may do an MRI every 2 to 3 years. Whereas certain cysts that are higher risk, it might be every year, alternating an MRI with an endoscopic ultrasound. So there is some variation based on specific characteristics of the cyst. Mm-hmm. It's not one size fits all for everybody.
Yeah, there is some nuance, and that's where it's really important for any patient or physician to refer patients with cysts to clinics that have experience managing these. There are multiple national guidelines that provide their own input on suggestions on how to manage these cysts. And most high-risk pancreas centers, such as Banner MD Anderson, will take all of these guidelines. They'll look through and come up with one joint guideline that makes the most sense for that particular patient. So there is a lot of value, even if it seems pretty obvious on the surface, to getting that second opinion or that second consultation, because there's a lot of data out there. And you want to just make sure that you've tailored your treatment plan to that particular patient's scenario.
Dr. Ramanathan, you had mentioned earlier in the conversation that cysts are liquid-filled tumors on the pancreas, but can you share with us a little bit more about the solid tumors that are formed or found on the pancreas?
Absolutely. When we look at overall risk, solid tumors do pose a higher risk of potentially having pancreatic cancer than liquid-filled cysts. And when we look at solid tumors, there are some solid tumors that are pancreatic adenocarcinomas. That is the formal name for a pancreatic cancer. These are cancers that can spread. The other type of common solid tumor or solid mass, all same thing. The other kind of solid finding that can show up on a pancreas is something called a neuroendocrine tumor of the pancreas. And these are very variable in terms of how we manage them. And similar to cysts, there's a lot of risk stratification that goes into a pancreatic neuroendocrine tumor to understand how urgently it needs to be acted upon and whether it can just be watched rather than removed. And then the third type of solid finding on the pancreas is a very rare type of tumor called a solid pseudopapillary tumors of the pancreas. This is a rare tumor that really is seen at a lot of expert pancreas cancer centers, but ultimately these solid tumors are going to come down to either adenocarcinomas and neuroendocrine tumors. And while there are some important imaging features that might help your doctor figure out which one of these it is, advanced endoscopy and endoscopic biopsy really becomes the main way in which we differentiate these and in which we use to develop the treatment plan for these particular tumors moving forward.
Dr. Vignesh, do you have anything to add?
Yeah, I think solid tumors are the other big category, and often patients get told by their primary care doctor or other doctor, oh, you have pancreatic cancer, and they come with a lot of anxiety. But not all pancreatic cancer is the same. The common variety is adenocarcinoma, but there are other types of solid tumors that have, slightly different treatments and maybe even different outcomes. And it's very important for an interventional gastroenterologist to do a biopsy with an endoscopic ultrasound to make a specific diagnosis. So in addition to visualizing the tumor and seeing if there's any invasion or involvement of blood vessels around the tumor, what we call staging, it helps determine if they're operable or not. We do a needle biopsy, and 95 to 98% of the time we get a specific diagnosis often we're able to get tissue from these tiny needles that is adequate to even do molecular profiling of these tumors to understand what type of treatments may work better. And so it really helps patients to move to the next step based on that specific diagnosis.
And Bridget, it's really important to recognize that this skill set is something that's unique to a gastroenterologist that treats a lot of pancreatic cancers, because people like Dr. Vignesh, they have special training to allow them to not just get a biopsy, but to do that staging. So now the patient and the oncologist, they know what stage the pancreas cancer is, and to get enough material so that you can do some of these advanced tests on the pancreas tumor to understand if they may be benefiting from one type of chemotherapy, from another type of chemotherapy, or what kind of mutations are in the tumor. So this is, again, where it's so important to go to someone that does a lot of these, that knows a lot about these, so they can provide the patient and their doctors with the most information possible.
Thank you. I think that's really important as we talk about Banner MD Anderson Cancer Center, and we talk about the collaboration and that multidisciplinary approach. When we talk through what the patients have access to when they come to that pancreas cancer prevention clinic, can you share with us, Dr. Vignesh, some of the benefits? I know we've highlighted some of that continuity of care and the imaging and the management and the staging. Can you share with us, from a patient standpoint, what does that mean?
Yeah, thank you. That's a very important question. And one of the reasons I am at a place like Banner MD Anderson Cancer Center is we all work together as this interdisciplinary team to offer patients with cancer the best care. For example, if the patients initially referred to me, I perform the initial diagnostic procedure, such as an endoscopic ultrasound and a biopsy, and then make sure the patient has the appropriate scans. And then I will present that patient's complete case at our tumor board conference, where we have surgical oncologists, all types of oncologists, the pathologist, the radiologist. We review every step of the diagnosis, the staging, and then we all discuss the appropriate management based on guidelines, and we come to an agreement called the tumor board consensus. And then in addition to that, we have focused multidisciplinary clinics. We have one that's well established for pancreatic cancer, and that clinic is to take all that tumor board recommendation and coordinate the patient's care in a seamless manner. So patients with new diagnosis of cancer don't have to jump through hoops to get to the right doctor. And it really, really not only helps patients move quickly through the next steps, but it also alleviates their anxiety, and it gives high quality care.
Banner MD Anderson's Pancreas program is here to be a resource for the community as well as for patients. So from a community standpoint, we offer a lot of resources where we can partner with any of their other doctors to get them whatever they need. So if they need some advanced GI endoscopy experience, we're happy to provide that. We've got great genetic counselors that we're happy to work with our community partners with. We've got great nutritionists, surgeons, medical oncologists. So we're here to work with any community partner that a patient has that they're interested in staying with. At the same time, we also have a true soup to nuts program where we are able to take care of patients from the screening, early diagnosis, all the way through the treatment, the management, the nutrition, the genetics, clinical trials, the whole 9 yards. And so really here at Banner MD Anderson, our vision, our model is to be both a resource for the community, but also to be a resource for patients.
So Dr. Ramanathan, can you share with us a little bit more about signs and symptoms that a patient may be experiencing with pancreatitis, or if they do have a pancreatic cyst?
Yeah, so the challenge, as most of our listeners know, is that pancreas cancer has very vague symptoms. There isn't one slam dunk thing that a patient is going to feel that's going to be related to pancreas cancer. Even things like jaundice, which is yellowing of the eyes and skin, is a fairly late finding of pancreatic cancer. Certainly, if anybody has any yellowing of their skin, yellowing of their eyes, darkening of their urine, those should be emergency signals to get to their primary care doctor as soon as possible or to the nearest ER. That needs immediate attention. But if we take that out of the picture, it really is a matter of awareness. We know that pancreas cancer is one of the cancer where there is some rising incidence. So any unexplained weight loss, any back pain, any diabetes that is new, those should all be further evaluated with some kind of imaging of the abdomen, whether that's a CT scan or an MRI. Similarly, if there's a patient with a family history of pancreatic cancer, That includes any first-degree relative or any 2 second-degree relatives. So this is one brother, sister, mother, father, child, or 2 aunts, 2 uncles. Any of those folks should start getting screened for pancreas cancer at the age of 50 or 10 years prior to the earliest diagnosis. So if you take Susie Joan, who has 2 aunts on the same side of the family diagnosed with pancreas cancer, if the youngest aunt was diagnosed at the age of 52, she needs to start annual MRI screening at the age of 42. If the same patient had a father that developed pancreas cancer at the age of 80, that patient needs to start pancreas screening at the age of 50, even without symptoms. But I would encourage all of our patients and primary care colleagues to keep diabetes in mind as one of the early markers of a potential pancreas cancer. If there is a patient that recently developed diabetes without another cause, they need to have cross-sectional imaging as a way of potentially finding this early. But it is a challenge because we don't have better testing for it. There are, at this point, no blood tests that are reliable enough to be used in the screening setting. There is a blood test called a CA19-9 that we use for monitoring pancreas cancers that we suspect or have already diagnosed. But barring that, there is no screening blood test. So it really does come down to imaging as the primary screening modality.
I agree with everything that Dr. Ramanathan said. Pancreatic cancer often does not present with symptoms, and that's a well-known challenge. And symptoms are often late in the disease and nonspecific. Having said that, if a patient has upper abdominal pain that does not go away and does not have a diagnosis, I would have a high index of suspicion. Pain in the upper mid-abdomen could be common causes of peptic ulcer disease, pancreatitis, pancreatic cancer. But often we see patients who've presented somewhere with abdominal pain, and then later we see that they unfortunately have a pancreatic cancer. So I think the pain does not go away. And if there's unexplained weight loss, new jaundice, even though those are late symptoms, they warrant immediate medical attention. And sometimes the stool color can all of a sudden get light, their bowel movements. That's yet another sign. And the point about the new diabetes, there's been a lot of research over the last 10, 15 years. There's a type of diabetes that can happen with new pancreatic cancer. And that's very important for all primary care physicians to be aware of. Or patients with known diabetes with sudden worsening, that is a red flag. But patients who do have higher risk based on family history or family members with certain genetic predisposition, if they have any doubt, they should come to a center like Banner MD Anderson Cancer Center, where we do have pancreas cancer prevention clinic, so we can better gather information and educate them about their risk.
Well, thank you both for your expertise, and thank you both for your time and for sharing with us the importance of early diagnosis with pancreatic cysts.
Thank you, Bridget.
Thank you, Bridget.
To learn more about the gastrointestinal cancer services available at Banner MD Anderson Cancer Center, please visit us at bannerhealth.com/cancer. Thank you for listening, and we'll see you next time on Making the Rounds.